Welcome to the meeting tonight. It's never as much fun when we can't interact kind of face to face, but this is kind of where we're at today. So hopefully you guys will have some questions, challenge the thought process, tell me that I don't know what I'm doing, whatever you want would be great at the end. Any feedback's appreciated. Tonight we're going to talk a little about the Illuminos solution. Is early range of motion possible in osteoporotic proximal humerus fractures? And I think it's a great topic, and we'll kind of get into why I think proximal humerus fractures are interesting. But let me just tell you a little bit, if you don't already know about the IlluminOss implant. It's an intramedullary implant. It's a little bit different than anything you might be used to working with, in the sense that you insert it really in a liquid form. So we put a very small balloon inside the intramedullary canal. It's not rigid, it's flexible with a liquid monomer that expands and meets the confines of the intramedullary canal. So the nail gets as big as the canal, really as big as you want it to get. And then we hit it with visible light, a blue light from that part of the spectrum, and that starts the chemical reaction of the monomer, which changes it and cures it from a liquid to a solid nail. The nail itself we can drill into. It'll take a screw. It pushes against the bone, and it's got a 510 classification from the FDA as an intramedullary nail, and we'll go over some of its indications. But that's the Illuminos solution, or photodynamic implant. Here's what it essentially looks like. It comes in a couple of different predefined shapes. It's either straight, or it's a tapered device where it goes from smaller on one end to bigger or more bulbous on the other end. The balloon itself that you're filling with the liquid is made out of Dacron, and it will reach a defined size. It doesn't have to reach that size or diameter of the balloon. Any other structures surrounding it, like bone, will contain it to a smaller size, but it will eventually fill completely. It has this black marker on it that you see here illustrated, but really radiographically it tells you the extension of the nail, like where the edges of the nail are, and you'll see that on the radiographs. This is kind of what the system looks like. Again, we inject the nail, the balloon fills up. You see the fiber optic cable coming up in this area down into the middle of the nail that delivers the blue light. And the blue light comes out of this fancy Norwellian box over here that lights it up and cures it. And this is just another illustration of how it works. On the right, you can see the balloon actually expanding in a confined space. Over time, you see the radiolucent marker getting a little larger, and on the left, you just see a schematic representation of how the balloon doesn't necessarily have to become a cylinder. If you look down at the bottom here, it'll just fill the confines of the intramedullary canal. And so that's what makes it different. Tonight, we thought we'd talk about proximal humeruses. This is one of the areas that I've developed an interest in utilizing the device, not as a standalone device, but as an augmentation for internal fixation. And I think proximal humeruses are a good place to explore new technology, because if you really think about particularly the geriatric proximal humerus, we have a lot of options for fixing those. And I think that's because they're challenging. And they're challenging because we have bone quality issues. We have short, small segments of bone we're trying to gain fixation in. We're really trying to get durable mechanical stability that will allow early motion and maybe even weight bearing. And, you know, in most instances, most of the things that we try, with the exception of a replacement or a very specific replacement, a reverse shoulder, really lacks the stability for early motion. And the lack of early motion leads to stiffness and muscle weakness and really diminished function. So a lot of times you can control discomfort, but the patients never really achieve reasonable motion again that's functional, and that can be devastating in someone who lives alone or who, as they age, really are requiring on the greatest amount of mobility possible to maintain independence and functionality. So we know they're challenging because just if you look at this slide, I mean, over 25 years of doing it, we got a lot of solutions that have evolved over time. I mean, we've done percutaneous pins. Maybe that's not a good idea for an older person, but some of the solutions I didn't even put up here, tension band and cables. The point is that we're always coming up with a new solution for this fracture, whether it's fixation with something we made, like a homemade blade plate or a pre-made blade plate, and then of course locking plates, which we're going to solve all of our problems that haven't necessarily. Intramedullary devices with all kinds of different proximal locking options, and of course hemiarthroplasty, total shoulder replacement, and reverse total shoulder replacement. So whenever I see a lot of options, I always wonder, or it makes me think that there's not really any one good solution. And so maybe we should look further or look for another answer. And so just as there's so many solutions, I mean, you can go through all those solutions and see all the associated failures: loss of fixation, loss of reduction, non-union, ongoing discomfort, and of course, we already talked about loss of motion and function. And so many devices, yet we still see failures on a regular basis. So the question really is can IlluminOss potentially change that? And I think there's a strong possibility it certainly can help with these fractures to minimize some of these complications and to gain better functional goals. So yes, these can be challenging. And as I said, we got to keep looking at it. We got to keep trying different things. And as you've seen over time, you know, we get a little bit better at things, and eventually we kind of figure out something, but is it really the right way, or is it the best way? So sometimes we get things done, but maybe we can be more minimalistic. Maybe we can get better function if we really study why things fail. So whenever we see multiple solutions and common failures, we really have to ask ourselves, why do things fail, and what can we control, and what can we not control, but what can we augment for? So in the proximal humerus, the things we can control is our implant choice, and we can also control to some extent, based on our ability, the quality of the reduction. So a good example of that is that I'd say, you know, for people who believe in internal fixation and plate internal fixation, locking plates, you know, almost 20 years old for the proximal humerus, not quite, we're going to be the end-all solution. But as I showed you in those prior slides, they continue to fail. And what are the predictive factors for failure in the proximal humerus? So a long time ago, back in the my early days, we published an article looking at locking plate fixation and did an analysis of efficacy and really looked at, you know, what situations resulted in failure. And what we found is it didn't have anything to do with the number of screws, or at least in our case series, or how close we got them into subchondral bone, where the good bone's believed to be. But we saw the number one predictor for failure was really reducing the fracture in varus, or not bringing the fracture out of varus. And so that was the number one predictor of failure, even though you were using this new technology. And that can be related to comminution there, or lack of medial cortical contact. So regardless of what device you're using, locking plates, nails, augmentation with Illuminos, it's still important to obtain and maintain a reduction that's as anatomic as possible and allows you to gain the support of the medial cortex. Again, here, humeruses fail due to lack of augmenting the fixation or protecting the fixation with medial support. And so here you can see a locking plate, again, that fails as things collapse into varus, likely because we never got them out of varus in the first place. So ways of dealing with that is the reduction. And then, of course, people have started talking about augmenting with intramedullary devices like fibular struts, which is difficult at best. And I think IlluminOss can give us a lot of support in that area to prevent varus collapse over time. So the things that we don't control is bone quality. And we know that as people age in the proximal humerus, not unlike the femur, we see an absence of bone with the exception of the subchondral area. So as you see, the 30-year-old female compared to the 70-year-old female has lost all this cancellous bone in the mid to lateral portion of the proximal humerus. So there's really nothing to support our fixation here. And so what can we do about that? And what can we do about bone quality? And what we can do is we can potentially augment that missing bone with an intramedullary nail that fills that void to the space that's there to occupy. And that's what Illuminos can do for us. It fills and supports and stabilizes the fracture. It provides the benefit of a fibular strut without all the incumbent surgical dissection, the risks of allograft, et cetera, and on, and the customization of the allograft that's required. So this is not to mention the fact that it will also augment our fixation, our plate fixation, if we use it in conjunction with an internal fixation device or plate, because we can now drill into the structure, obtain good combined support of our implant, and continue to support and prevent varus collapse of the humeral head over time and allow healing. And so schematically, this is what it would look like. On the left, you see the good subchondral bone and interosseous bone here. And then just envision this as an intramedullary device on the right that fills the canal, gains purchase in the distal aspect of the canal, and then supports or struts the remainder of the bone in the humeral head. And that's what we're really going to try to achieve with the IlluminOss device. So again, why is it different? Well, we can nail in asymmetric bones. We can really put the device we can insert the device anywhere we want, as long as we can gain access to the intramedullary canal, because it doesn't have to be straight. The device won't deform the fracture. It'll just fill the space available to it. And we can use non-traditional starting points. We don't have to use traditional nailing starting points. We've had great success placing this through the Navassier portal when we can't gain access to the center portion of the head outside of the acromion. We go between the acromion and the clavicle itself, and we can gain entry there. And as I said, the implant can be drilled into, so the plate supports and holds the implant up, and the screws help hold the head up and get good fixation distally. And it's a small incision, and of course it's radiolucent, so we can still see the canal and we can still see the healing that occurs around it. And it's my belief that the support is substantial enough that in these patients, we really don't require restriction after surgery. So they're post-operatively, they're placed in a sling. Their motion is not restricted in terms of active or passive motion. And if they need to use an ambulatory device, we'll allow them to use a platform walker if they need to mobilize with their arms. And so it seems to be a very stable and promising implant that can achieve the goals that are important in the older population of early motion and unrestricted function. And so with that, I'd like to share a case with you showing you one of our cases. And I'm sure that people will have opinions about how you can treat this. And remember, there are a lot of options for this fracture. So this was an older gentleman, 70 years old, had a fracture dislocation of his shoulder from a seizure. These were his x-rays, and ultimately this was his CAT scan. So posterior dislocation with a good three-part proximal humerus fracture. So for full disclosure, I'm not really much of a reverse shoulder replacement person. And I'm sure that for some of the surgeons in the audience, that might be a go-to procedure here. But I don't know. I really think if you can keep your own equipment and achieve the goals that we talked about, that might be a better solution than replacing things, and because it's such a much more aggressive operation. But again, we're early in the stages of learning about the proximal humerus and IlluminOss and combining it with plate fixation, but I do think it provides a viable option. So with that, we went ahead and reduced the humeral head and provisionally fixed it with a K-wire. And then the way we essentially do this after we get the provisional reduction is we use the plate to further the reduction. And so generally we'll place a couple of screws through the plate, posterior or superior, to avoid the entry point of the nail. And then we'll use a unicortical screw or a clamp distally to hold the plate on the bone, and that maintains our reduction. Then we have used the Illuminos device in inner, just medial to the greater tuberosity, and we place it down the intramedullary canal. We inflate it, harden it with the blue light until it becomes a solid, and then we place all the remaining drills in a standard fashion through the device and into the subchondral bone. I do think it's important when you look at the x-ray, particularly these two inferiorly, as we try to extend the Illuminos device a couple centimeters below the lowest aspect of the plate, so we avoid a stress riser at the end of the plate. You could potentially make the device shorter, but we don't have one that's shorter. So in most cases, here you're going to see the Illuminos device extending past the plate. And then the patient's closed, placed in a sling for comfort, and as I said, unrestricted post-operatively in terms of active and passive motion. So this gentleman so far did pretty well. Here's his first post-operative x-ray, 6 weeks after surgery with unrestricted motion. He's had no collapse or penetration of the screws through the humeral head, though one's quite close there, and no loss of his reduction. And here's an example of his motion in the office 6 weeks after surgery. And I think that's pretty reasonable motion 6 weeks after the injury for really no therapy, just using your arm for day-to-day activities, you know, doing Codmans, and we did teach him how to do some assisted overhead function. And then here he is. This is his 3-month follow-up. Again, no change in position. It appears that his cortical structures are reconstituting, and there's no evidence of fixation failure. And then this was his motion at his 3-month follow-up. So considerably better. He was in therapy for these 6 weeks, and this is what he looked like on the lateral. So, you know, we've got about, I think, 6 cases of these now. We haven't had a failure yet. One person that I know of has gone on to, you know, advance their already pre-existing arthritis. But beyond that, we haven't had a failure, and most people seem to be regaining motion pretty quickly. And and I think one of the reasons they can do that is that the fixation construct is so stable that they don't seem to have much discomfort. But again, very preliminary but promising results. And that really concludes the